Hi dear friends, very warm welcome to all of you. Welcome to this INI CET recall questions from Pediatrics. My name is Dr. Pankaj Tikku. I'm your pediatric faculty. I'm your pediatric faculty, and I will be going through these INI CET, the pediatric questions of the last 3 years. So we'll be covering questions of 2020, 2021, and 2022. So the main aim, the main objective will be to cover the questions so that you are able to understand and know what are the pattern of questions from pediatrics that are asked, make you confident from these topics from which the questions have been asked. And many of these questions sometimes are repeated also. So you should be able to feel confident that when you have done these questions, there are some questions which can be repeat as it is and can be very helpful for the upcoming INICET exams. So we'll first be starting with the INICET questions from the year 2022, the recent November 2022 questions, in which I will be taking up the pediatric questions. Let us move on to question number 1. So question number 1 is a question where they say an 11-year-old child is diagnosed to have acute rheumatic fever with no carditis. So there is a child who is an 11-year-old child. He has come to you and you have diagnosed him with acute rheumatic fever and there is no carditis right now. They are asking the duration of penicillin prophylaxis in this patient would be for how many years? Would it be for 5 years? Would it be for 10 years? Would it be for 20 years? Or would it be for 40 years? So what is the duration of penicillin prophylaxis that you would recommend in this patient? So first of all, acute rheumatic fever, I'm sure you are all very familiar with this name. This is a very important cause of acquired heart diseases in children. It's one of the most common, in fact, it used to be the most common cause of acquired heart diseases in children. However, we are seeing now less cases of acute rheumatic fever these days. And in fact, in some books, they have written that possibly Kawasaki's disease has now replaced acute rheumatic fever and rheumatic heart disease as the most common cause of acquired heart disease. We are not talking about congenital heart diseases. We are talking about acquired heart diseases. So in many developing countries, they say Kawasaki's disease has probably replaced acute rheumatic fever and rheumatic heart disease as the most common cause of acquired heart disease in children. Well, we do not have any concrete data, but first of all, you should know that we are nowadays seeing lesser number of cases of rheumatic fever in comparison to what we used to see in the past, especially when I was doing my PG. At that time, we were seeing more number of cases. Now we are seeing actually less number of cases of rheumatic fever. Now, without going into too much of detail, let me quickly jump to the management of rheumatic fever. So rheumatic fever has major criterias, minor criterias, and you know the major criterias includes carditis, arthritis, erythema marginatum, subcutaneous nodules, Sydenham scoria. So if there is only arthritis in the child, suppose there is no carditis, only arthritis in the child, what should be the management of this child? The management of this child that we prefer is only aspirin. Similarly, if there is only carditis in the child, but without any cardiomegaly or heart failure, we again prefer treating these children with aspirin. So carditis and arthritis, carditis without cardiomegaly or heart failure, which means a mild form of carditis, and all forms of arthritis in rheumatic fever should primarily be treated with aspirin, not steroids. So that is the first thing that you should know. Steroids are usually only recommended when we are treating severe form of carditis in rheumatic fever where there is association with cardiomegaly or heart failure. So only when carditis is severe and is associated with cardiomegaly and heart failure, only then the drug of choice of rheumatic carditis should be prednisolone. Otherwise, rheumatic carditis, when it is not associated with cardiomegaly or heart failure, which means a mild form of carditis, and all forms of rheumatic arthritis should be managed only with aspirin. So that is the first lesson that you should learn. Now, coming to the prophylaxis against recurrence of rheumatic fever, I'm sure you are all aware that rheumatic fever has a very adverse effect on the heart. So whenever there is recurrences of rheumatic fever, and rheumatic fever is known for its recurrences, it's notorious for its recurrences. So whenever there are recurrences of rheumatic fever, it often can have various type of adverse effects on the heart, especially leading to regurgitant valvular lesions initially. And later on, when again and again the valvular lesions occur because of rheumatic carditis involvement, ultimately stenotic valvular lesions will develop. So rheumatic carditis is not good for the heart, and that is why we need to provide these children with secondary prophylaxis. That means once a rheumatic fever has developed in the child, you need to give the child penicillin, and this penicillin needs to be given every 4 weeks. So now they say every 3 to 4 weeks. This penicillin should be given every 3 to 4 weeks, and this should be given in a dose of 6 lakh units if the child's weight is less than 27 kgs, and it needs to be given at a dose of 12 lakh units if the child's weight is more than 27 kgs. Intramuscular penicillin given in a dose of 6 lakh units if the child's weight is less than 27 kgs, and 12 lakh units if a child's weight is more than 27 kgs, and this needs to be given every 3 to 4 weeks. Now, the next question is for how long this prophylaxis needs to be given, and that is primarily what our question is based on, the duration of prophylaxis. So there is a lot of discrepancy. I'm talking about now the recent guidelines on rheumatic fever in children, the Indian guidelines, what they recommend. So the recent Indian guidelines, now they recommend that whenever you are given penicillin in a child for prophylaxis and there is no carditis, then it should be given for either 5 years duration or till 21 years of age, whichever occurs, whichever is longer. So either you give it for 5 years duration or give penicillin prophylaxis till 21 years of age, whichever is longer. In case the child is having carditis, but there is no heart disease right now, that means the carditis has healed. So it should be given for 10 years duration or till 21 years of age, again whichever is longer. And in case there is presence of a residual heart disease, that means rheumatic heart disease has already developed, then you obviously need to give it for a longer period of time. So they recommend that you give it for 10 years duration or you give it till 40 years of age. Preferably, many times they recommend lifelong, which obviously is not a very feasible option for many patients. Therefore, at least till 40 years of age, you need to give prophylaxis in case a rheumatic heart disease has already developed. So I'm repeating again, if there is rheumatic fever, but there is no carditis, so you give it till 5 years duration. In the past, many guidelines used to suggest till 18 years of age. Even now, many guidelines still suggest till 18 years of age. But I think Indian guidelines, which are more concrete, should tell that 5 years duration or till 21 years of age, whichever is longer. In case there is carditis, but there is no residual heart disease, that means that carditis has healed. So give it for 10 years duration or till 21 years of age, whichever is longer. And in case there is a residual heart disease which has already developed, then give it for 10 years duration or till 40 years of age. And preferably in many cases, you will need to give it lifelong. If not lifelong, at least give it till 40 years of age. So many of you have, yes, 5 years. So 5 years, many of you have written. I would not say this answer will be 10 years. I would say it is 5 years because they are saying the child has no carditis right now. So because there is no carditis right now, as I told you, it should be 5 years duration or till 21 years of age, whichever is longer. In case they would have asked that carditis has developed but has healed, then it should have been 10 years duration or till 21 years of age. And in case they would have asked in the question, a child of rheumatic fever with presently a rheumatic heart disease, so then that means that the child needs to be given longer prophylaxis, 10 years duration or till 40 years of age. So I hope this is now crystal clear what is the duration of prophylaxis which you should mark for children with rheumatic fever, especially according to the Indian guidelines. Next we come to question number 2. Now this again was an INI CET question which said that the parents of a 5-year-old child bring the child to you and they say that they have noticed that the child is tired most of the times, and they also notice that he feels shortness of breath on climbing stairs. So there is history of exercise intolerance. This is not exercises, but it is exertional intolerance. So whenever the child is exerting, the child is feeling breathless. The child is also breathless when the child is kept in the supine position, which is another form of saying that the child is having orthopnea. So the child appears to be having breathlessness. The child appears to be having dyspnea. And the child also appears to be having orthopnea. All of these are well established findings of congestive heart failure in a child. So congestive heart failure in an older child will present with findings which are exactly similar to the findings of heart failure in an adult. So there will be features of breathlessness, there might be features of exercise intolerance or exertional dyspnea, there might be features of orthopnea. The challenge is always to find heart failure in a young child, a newborn or an infant. So in an infant, many times the features of heart failure may be a little different, and therefore the diagnosis of heart failure in infants may often be missed. So what are the features of heart failure in an infant? When would you identify that there are heart failure in an infant? Well, whenever there is a tachycardia, and especially in tachycardia, the heart rate should be more than 150 per minute. Whenever there is a significant increase in the respiratory rate, which means there is a significant tachypnea, and also whenever there is development of hepatomegaly. So development of tachycardia, development of tachypnea or fast breathing, and whenever there is heart failure, there will be hepatomegaly in a young infant. So in infants and newborns, these are the findings of heart failure. While in older children, the findings of heart failure will be breathlessness, dyspnea, orthopnea. Now he is asking investigation for diagnosis that you would do. Now please understand that he is asking what is the investigation for diagnosis. See, the best investigation for diagnosis of heart failure according to me should be an echocardiogram. We might also go in for a chest x-ray as an initial investigation wherein we might find cardiomegaly, and that may help in telling us the possible cause of heart failure. But because the question is which of these investigations is used for diagnosis of this condition, I personally feel the best test for diagnosing this condition will be an echocardiogram. Let me see how many of you have answered. So there have been varying type of answers. Some have answered it as A. See, A is a good answer, but please understand it's the first test that we go in for. But it will never be helpful in identifying, diagnosing the condition. A chest x-ray may at best show you cardiomegaly. How will you know that this cardiomegaly is basically because of heart failure? Cardiomegaly can be an underlying cause of so many conditions. Because the question is what is the investigation for diagnosis? Therefore, definitely the investigation for diagnosis I don't think can be chest x-ray. It can be an initial investigation, but not an investigation for diagnosis. For diagnosis, investigation has to be echocardiogram according to me. So according to me, those who have answered B should be the correct answer. A could be the answer if initial. Yes, very good. A could be the answer if they say initial investigations. So you might go in for chest x-ray as an initial investigation, but that definitely is not the investigation that will help you in making the diagnosis. Similarly, if you see choice B, MRI to rule out an enlarged heart, again I'm saying, how will an enlarged heart tell you that this is cardiomegaly because of heart failure? Heart failure can be basically with a normal sized heart as well. So in case you go by the criteria that cardiomegaly is related to heart failure, you will miss out on cases of heart failure which are associated with a normal size heart. If you go to choice C, spirometry, it has nothing to do with heart failure. So therefore, for me, the best way to diagnose heart failure in a child would be echocardiogram. So what will be the best investigation? I think the best investigation to make a diagnosis of heart failure in this child should be an echocardiogram. Heart failures, can be overload heart failures. This I have taken from my app. It is overload heart failures, or it can be heart failures because of failure of the cardiac pump. Overload heart failures can be basically left to right shunts. So all those left to right shunts, such as ventricular septal defects, such as patent ductus arteriosus, such as atrioventricular septal defects, they all will lead to overload heart failures. Similarly, overload heart failures can also be because of congenital heart diseases which are associated with increase in the pulmonary blood flow. So many cyanotic congenital heart diseases which are associated with increase in the pulmonary blood flow, like transposition of great arteries, like total anomalous pulmonary venous return, they all will lead to, again, heart failure. Then regurgitant valvular lesions, especially valvular lesions like mitral regurgitation, aortic regurgitation. So they all will lead to heart failure because of overload on the heart. So this type of heart failure is overload heart failure. But then there is another type of heart failure which is because of failure of the cardiac pump. So failure of the cardiac pump can be because of obstructions to the ventricular outlet. For example, if there is an aortic stenosis, if there is a pulmonary stenosis. So whenever there is obstruction to the outlets, cardiomyopathies, viral myocarditis, arrhythmias, especially heart blocks, they all can be again associated with heart failures, but these type of heart failures will be pump failures. They won't be overload failures, they will be pump failures. So there are many causes of heart failures in children, which are, as you are seeing on your screen, divided into overload heart failures and pump failures. I won't go into the details about the investigations. The investigations will again include, as I told you, initial investigation of chest x-ray. You might go in for an ECG because many causes of heart failures are because of congenital heart diseases. So ECGs are very important. Arrhythmias can be diagnosed by ECGs. Then echocardiogram is the best investigation. And management, you have various drugs that are used, including beta blockers, angiotensin converting enzyme inhibitors, diuretics, digoxin. So these are various drugs that can be used for the management of heart failures. Coming now to question number 3 of INI CET November 2022 exam. Choose the correct sequence regarding the management of status epilepticus in children. So status epilepticus is basically continuous seizures that are occurring in children. So I'm just giving you a very simplified way of defining status epilepticus. It is continuous seizure activities wherein the child either has continuous seizures or the child has recurrent seizures, and in between those seizure episodes the child does not regain consciousness. So what should be the sequence in which a child of status epilepticus should be managed? So they have said choice A is airway and breathing, choice B is IV lorazepam, choice C is midazolam, propofol and thiopenton, which means the anesthetics, and choice D is IV phosphenytoin. So let me see what you have answered. So most of you have answered B, which actually is the correct answer. So this actually is the correct answer. Whenever a child of status epilepticus will come to you, the first thing that you will like to do in this child will obviously be the stabilization. So always check for the airway, check for the breathing, circulation. Immediately connect an IV line. So stabilization is the first step that is required in any child who comes to you with a continuous seizure activity. This should be followed by the drug of choice, which can be IV lorazepam or can even be IV midazolam bolus dose. In fact, many times if the seizure activity does not get aborted or controlled with the first dose of lorazepam, you might after 5 minutes repeat the dose. The next drug that you will come to after lorazepam is IV phenytoin or phosphenytoin. So phenytoin or phosphenytoin will be the next drug that you will like to give in case the seizures are not getting controlled with IV lorazepam. In case the seizures are not getting controlled with phenytoin and IV phosphenytoin, then you might go in for other drugs such as sodium valproate. You may also go in for IV levetiracetam. You may go in for IV phenobarbital. And in case the seizures are not getting controlled, then you go in for IV midazolam infusion. So now the child has to be shifted to the ICU. So the child now needs to be shifted to the ICU. So till here you were managing the child in the emergency. So you gave lorazepam, seizures did not get aborted. You gave phenytoin or phosphenytoin, seizures did not get aborted. You gave valproate, levetiracetam, phenobarbital, seizures did not get aborted. Then you move on to IV midazolam infusion in the ICU. Also you go in for the anesthetics. So you go in for the anesthetics, the agents such as ketamine, propofol. So this is the sequence in which you need to move. So if we go back to our question, the first thing that we need to do is maintain the airway and breathing. The second thing that we need to give is to give IV lorazepam. That's the drug of choice. Then you need to give the child phenytoin or phosphenytoin, and then you need to move towards the anesthetics, the general anesthetics. So the correct sequence will be A, B, D followed by C. So I think most of you have correctly answered it as A, B, D followed by C. Coming now to question number 4. Question number 4 says most common gene mutation. Now this again is a November 2022 INICET question. Most common gene mutation which is seen in cystic fibrosis is related to. So please remember, cystic fibrosis is an autosomal recessive disorder. Cystic fibrosis is an autosomal recessive disorder which is associated with mutation. It is associated with mutation in the CFTR gene. So there is mutation of the cystic fibrosis transmembrane regulatory gene. Now more than 1500 mutations of this gene are known. Out of that, the most common mutation of CFTR gene is also called as the delta 508 mutation. What is meant by delta 508 mutation? It means there is deletion of phenylalanine from position 508 on chromosome 7. Deletion of phenylalanine from position 508 on chromosome 7. F stands for phenylalanine. 508 stands from the position on chromosome 7 where the deletion has occurred. So there are two choices related to phenylalanine, this choice and this choice. The other choices naturally are ruled out. So one choice is saying phenylalanine at 508 position, the other says phenylalanine at 708 position. So definitely the correct answer should be phenylalanine at position 508. And there are two channels which are controlled by this. One is the sodium channel and one is the chloride channel. So position 508 CFTR gene, which controls the movement of chloride across the hollow ducts of the body. That's the primary problem that happens in cystic fibrosis. So those who have answered A is correct, those who have answered B is wrong. It is delta 508 mutation. It's not 708, it is 508 mutation. That means deletion of phenylalanine from position 508 on chromosome 7. So when there is a deletion of these, what will happen is they will, so see this, what will happen here is that there is a CFTR gene which controls the movement of chloride and also partly the movement of sodium. So what happens is it causes chloride to be secreted into the lumen and it prevents sodium from being absorbed from the lumen. So this is the normal functioning of a CFTR. So what does the CFTR do normally? It causes chloride to be secreted into the lumen of the hollow tubes. For example, the pancreatic duct. So it will cause chloride to be secreted into the lumen and it will prevent sodium from being absorbed from the lumen. So as a result, what happens is sodium and chloride, they start increasing inside the lumen, which creates a high osmotic pressure inside, leading to water moving from low to high osmotic pressure. So that is why water starts entering inside the tubes, making the secretions of the tubes moist. So that is why the secretions of the tubes in the body, they become moist. The pancreatic secretions, they become moist. The bile secretions, they become moist. The airway mucosa, it becomes moist. So this is why CFTR is so important. By regulating the movement of chloride and sodium channels, it causes the secretion inside the hollow tubes of the body to remain moist. So when there is a mutation, that means the CFTR becomes defective. Now it will not be able to keep the secretions inside moist, which causes now the secretions inside the tubes to become dry, and that is the primary cause of all the problems in cystic fibrosis. The secretions inside the hollow tubes, they become dry whenever the CFTR protein becomes defective because of mutation. So the pancreatic secretions, they become dry, which leads to the development of exocrine pancreatic insufficiency. The bile secretions become dry, which leads to the development of conjugated jaundice. The airway mucosa becomes dry, which leads to thick secretions accumulating and blocking the airways, leading to chronic obstructive airway diseases. Because the airway mucosa becomes dry, the cilia are not able to perform their normal function. So there is recurrent chest infections. Meconium inside the intestine of newborns becomes dry. Meconium, you know, is the first stool of the newborn. It becomes dry. And when meconium becomes dry and starts obstructing the intestinal tract, it leads to what is called as a meconium ileus. So all these manifestations are because of the CFTR protein becoming defective. And why does the CFTR protein becomes defective? Because of more than 1500 mutations, of which the most common mutation is delta 508 mutation. So what is the correct answer? Deletion of phenylalanine at position 508 on chromosome 7, which is required for the movement of chloride and sodium across the hollow tubes of the body. Coming then to question number 5. Now question number 5 was a very pretty simple question which was asked in November 2022 AIMS exam. The child of 11 months presenting with cyanosis and breathlessness is brought to the emergency by the mother. The chest x-ray is given, which typically shows a boot-shaped heart. So I won't go into the details. It is a pretty simple question, I think, with a pretty simple answer. So what is the answer to this question? So whenever you have a boot-shaped heart, you always think of tetralogy of Fallot. Yes, very good. So tetralogy of Fallot is the correct answer. Whenever you have a sign of 3 appearance, you always think of coarctation of aorta. Whenever you think of sign of 8 appearance or a snowman's heart, you think of total anomalous pulmonary venous return. Whenever you have a egg on a string appearance, you always think of transposition of great arteries. And whenever you have a box-shaped heart, you always think of Epstein's anomaly. So these are the X-ray appearances that you get in children with different congenital heart diseases. A boot-shaped heart always indicates a tetralogy of Fallot. A sign of 3 always indicates a coarctation of aorta. A sign of A or a snowman's heart always indicates a total anomalous pulmonary venous return or a total anomalous pulmonary venous connection. Egg on string appearance always indicates a transposition of great arteries, and box-shaped heart always indicates Epstein's anomaly. So you people have correctly answered. This is a boot-shaped heart that is seen as a result of tetralogy of Fallot. Then there is another question, which is a question on febrile seizures in children. So the question is, which of the following conditions increase the risk of recurrence of febrile seizures in children? Now you must have heard, and I also teach febrile seizures in my classes. Febrile seizures are seizures or fits that occur with high-grade fever in young children. They typically are seizures that are seen in children between 6 months to 5 years of age. Most of these seizures occur with high-grade fever. Most of the seizures occur in high-grade fever in a otherwise neurologically normal child. So these are seizures that are commonly seen in children between 6 months to 5 years. They are seizures that occur with high-grade fever in an otherwise neurologically normal child. Now, febrile seizures are characterized by recurrences. So recurrences are very, very common in febrile seizures. Recurrences are very, very common in febrile seizures. It is usually believed that almost around 25 to 50% of febrile seizures are recurrent in nature. That means they actually are known to get repeated. In fact, I think these are very conservative figures. The figure actually for recurrence may be even higher than this. Now, what are the risk factors which increase the risk of recurrence? So let me see what your answer is. Some have given the answer as A, some have given the answer as D. Uh, Actually, there are two main group of risk factors for recurrences. One are the major risk factors and one are the minor risk factors. This is given in Nelson's textbook of pediatrics. So this is given in Nelson's pediatrics. So they have said that there are certain risk factors for recurrences in febrile seizures. These risk factors are divided into major risk factors, which include age less than 1 year. So if the child's age is less than 1 year, if the seizure occurs in a child with a fever duration of less than 24 hours, and seizures occur in children with fever between 38 degrees to 39 degrees centigrade. So these are major risk factors for recurrences in febrile seizures. So what are the major risk factors for recurrences? Age of the child less than 1 year when the first seizure occurs. Duration of fever was less than 24 hours when the first seizure occurred. And the first seizure occurred when the child had a fever which was between 38 degrees to 39 degrees centigrade. So these are major risk factors. The minor risk factors includes a positive family history of febrile seizures, or a positive family history of epilepsy. It's very important. If there is a positive history of epilepsy or a positive family history of febrile seizures, it definitely will likely increase the recurrence risk of febrile seizures. Then febrile seizures which are complex febrile seizures, and I have told in my classes what are complex febrile seizures. Febrile seizures which are focal, febrile seizures which are long duration, febrile seizures which are multiple seizures. They all are likely to be complex febrile seizures. And complex febrile seizures not only will increase the risk of epilepsies later on, will also increase the risk of recurrences. Then febrile seizures in children in daycare centers, male gender, and febrile seizures associated with low sodium at the time of presentation with febrile seizures. So these are some of the major and minor risk factors which increase the risk of recurrence of febrile seizures. So if you actually see or you go back to our question once again, they're asking which of the following condition will increase the risk of recurrence. So this, as I just now told you, is a major risk factor. Temperature between 38 to 39 degrees is again a major risk factor. Duration of fever less than 24 hours is again a major risk factor. But this is definitely not a risk factor for the recurrence of febrile seizures. So therefore, the risk factors which increase the risk of febrile seizures, increase the risk of recurrence of febrile seizures, therefore are 1, 2 and 3, which are major risk factors for recurrences. So therefore A should be the correct answer. Duration of fever less than 48 hours, duration of fever more than 48 hours is definitely not a risk factor for the recurrence of febrile seizures. One more thing that I would like to inform you here is that recurrence, as I told you, is generally a rule in a large number of febrile seizures. So even if no risk factors are present, none of the above risk factors are present, the risk of recurrence still in a febrile seizure will be 12%. Risk factors will definitely increase the risk. But if no risk factors of recurrence are present, still, as you can see, the risk of recurrence in a febrile seizure will be 12%. If there is one risk factor present, the risk of recurrence will increase to 25 to 50%. 50%. 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50% 50 If there are two risk factors present, then the risk of recurrence will increase to almost around 50 to 59%. And if three or more risk factors are present, then the risk of recurrence will increase to almost around 73 to 100%. So that very clearly shows you that if the child is having a febrile seizure, the risk of recurrence is very, very high, even in the absence of the risk factors. But when the risk factors are present, then exponentially the risk starts increasing. With one risk factor, the risk starts increasing to almost around 25 to 50%. With two risk factors, the risk increases to almost around 50 to 59%. And with three or more risk factors, the risk may increase up to around 70 to almost 100%. So this is the risk factor recurrence risk. Now there is a question, more than 3 episodes in 6 months. So that is not the risk factors for recurrence. That is actually the risk. So when the febrile seizures start becoming very, very recurrent, then basically you need to start these children on intermittent prophylaxis with anti-epileptic drugs. So what you are writing, Mansi, is basically the indication for starting intermittent prophylaxis with anti-epileptic drugs. I've told in my classes that usually anti-epileptic drugs, oral anti-epileptic drugs, are not routinely recommended for prophylaxis in rheumatic fever, in febrile seizures. It's not routinely recommended. But if the febrile seizures are 3 or more than 3 seizures in 6 months, or 4 or more than 4 seizures in 1 month in the last 1 year, then you need to start these children on oral anti-epileptic. So what you are writing is actually an indication for starting oral anti-epileptic drug in children with recurrent febrile seizures. Coming to question number 7. So question number 7, again, INI CET November 2022 was, which of these is an alternate method? Which of these is an alternate method of measuring the height of the child? So which of these is an alternate method of measuring the height of the child? So see, standard wise, the best method to measure the height of the child is a stadiometer. So as you must be knowing very well, the supine length of the child is measured by means of an instrument which is called as an infantometer, and the standing height of the child is measured by means of an instrument which is known as a stadiometer. However, in case there are certain children who are not able to stand erect, for example, a child who has spinal deformities, then are there any alternative methods to measure the standing height of the child, or alternative methods to measure the height of the child? So let us see the choices one by one. First choice they have written is crown rump length. Crown rump length definitely is not the correct choice here, because that is more commonly used for fetal measurements. It's not something for measurement of a child after birth. Crown rump length is more commonly used for fetal measurements. Similarly, head circumference. Head circumference has nothing to do with the height of the child. It's not correlated with the height of the child. Arm span. What is arm span? So arm span is you make the child stand with his arms wide apart and take the distance of the arm span from the tip of the middle finger on the left side to the tip of the middle finger on the right side. So that is arm span. Normally, arm span of a young child is always less than the standing height. The arm span becomes equal to the standing height. The arm span of a child becomes equal to the standing height at the age of about 10 years. So normally the arm span is always less than the standing height in a child below 10 years of age. The arm span becomes equal to the standing height at the age of 10 years. So arm span is basically the best way by which you can correlate with the height of the child. If you see the other option is knee length. Knee length is more like the sitting height of the child. And the sitting height of the child more commonly correlates with something like the upper segment of the child. It does not correlate with the total height. It correlates more commonly with the upper segment of the child. So therefore, this again will not correlate with the height of the child. Therefore, according to me, the only measurement which best can be used, it's not a very accurate measurement, but at least we can say the best alternate method for measuring the height of the child is the arm span. And arm span becomes equal to the standing height between 7 to 10 years. Yes, around 10 years is the time when the arm span becomes equal to the standing height of the child. So you are correct. Arm span, most of you have answered correctly. Arm span is equal to the standing height at the age of about 10 years. So that is best way or a best correlate measurement of the height of the child. Coming to question number 8, which again is a question from November 2022. Which of these is correct about UTIs in children? So they're asking which of the statement is correct about urinary tract infection in children. So first, they say bowel bladder dysfunction can cause recurrence of UTIs. So this, according to me, is a correct statement. There are children who have, especially the school age children, who have problems of passing urine. So many of these children, for example, have problems such as underactive bladder. So they hold the urine for very long periods of time. There are children who may have overactive bladders. So many of these school children have problems which are related to their passing of urine, their urination. Constipations again can be present in many children, and when there is constipations, they can often be dilated rectum. The dilated rectum can press on the bladder, can again lead to bladder outlet obstructions. So the point is that all children who have bladder bowel dysfunctions have somewhere obstructions or collection of the urine in the bladder. I just now told you constipations will lead to collection of urine in the bladder because there will be a bladder outlet obstruction. Similarly, underactive bladder children will have urine which is held up in the bladder for long periods of time. So all of these serves as nidus for infections. So there is definitely risk of recurrent UTIs in children who have bladder bowel dysfunction. So this is correct. This is a correct statement. Children who have bladder bowel dysfunctions often have recurrence of UTIs, and this is the reason why a child with a bladder bowel dysfunction and a vesico-ureteric reflux needs to be given antibiotic prophylaxis for long periods of time, because they have a very high risk of UTIs which can cause damage to the kidneys. So A is a correct statement. Coming to B, most common cause of UTIs in children is S. pneumonia. This is definitely a wrong statement. It is E. coli. E. coli is the most common cause of UTIs in children. So this definitely is a wrong statement. Then MCU should be done in recurrent UTIs. This is a correct statement. Micturating cystourethrogram is basically the gold standard test for detecting vesico-ureteric refluxes. It's a gold standard test for detecting vesico-ureteric refluxes. So any child who has recurrent UTIs, you should definitely root out of vesico-ureteric reflux, because VUR is one of the most common causes of recurrent UTIs in young children. So if there is a child with recurrent UTI, you should always think of a VUR, an underlying VUR. So C is also correct. And D, all children with UTI should go ultrasound. Definitely. This is one of the imaging modalities that should be done in all children who present to you with UTIs. Constipation is also a common cause of UTIs in children. Absolutely correct. And that is why as I again and again is saying, children who have bladder bowel dysfunction, which includes constipations also, have a very high risk of recurrent UTIs. So in this, A, C, and D are the correct statements. Bladder bowel dysfunction can cause recurrence. This is correct. MCU should be done in all children who present to you with recurrent UTIs. This is correct. And all children with UTI should undergo ultrasound. This is correct. So according to the current recommendations, any child who comes to you with the first UTI, the imaging test that you will actually do will depend upon the child's age. So if the child's age is less than 1 year, the child should undergo the ultrasound of the kidneys and the urinary tract. They should undergo a micturating cystoarthrogram, and they should undergo a DMSA scan. So that is for all children who come to you with the first UTI and are less than 1 year of age. Any child who comes to you with the first UTI and is between 1 to 5 years of age, any child who comes to you with the first UTI and is between 1 to 5 years of age, it is always preferable to do an ultrasound of the kidney and the urinary tract and a DMSA scan first. MCU should be avoided as much as possible because it involves urethral catheterization. However, unfortunately, it's the gold standard method to diagnose a VUR. So in a child less than 1 year of age, it is a must. You have to diagnose VUR. But in a child between 1 to 5 years of age, we first prefer doing an ultrasound in DMSA and wait for the reports. In case the reports of these tests are normal, then we recommend nothing else to be done. But if the reports of these tests are abnormal, then we recommend that the child should undergo an MCU. So you are not going in for MCU initially, you are going in for MCU only when the ultrasound and DMSA reports are abnormal in a child between 1 to 5 years. And if a child comes to you with the first UTI after 5 years, then the initial test should only be ultrasound. Wait for the ultrasound reports. If the ultrasound report is normal, nothing else needs to be done. If the ultrasound report is normal. But if the ultrasound report is abnormal, then you need to go in for an MCU and a DMSA scan. So basically we are recommending the tests only after knowing what is the age of the child. Less than 1 year, all the 3 tests. 1 to 5 years, ultrasound and DMSA initially. If the reports are normal, then nothing. But if the reports are abnormal, then MCU. And in the child who is more than 5 years, ultrasound initially. If the report of ultrasound is normal, then nothing. But if the report of ultrasound is abnormal, then go in for an MCU and a DMSA scan. So this is the recommendations of evaluating a child who comes to you with the first UTI. And the recommendation is to identify vesicoureteric refluxes as an underlying cause of UTI in young children and any damage to the kidney because of the vesicoureteric reflux. So why ultrasound kidney to rule out? See, ultrasound kidney is usually done because vesicoureteric refluxes are commonly co-associated with many other congenital abnormalities of the urinary tract. So for example, I'm just giving you an example. A very important cause of a vesicoureteric reflux in young children may be a posterior urethral valve in a male infant. So there will be presence of a PUV, and PUV is then leading to a vesicoureteric reflux. So if you do an ultrasound, you will be able to identify PUV. Ultrasound in a child with PUV will typically show that keyhole sign. Similarly, uretroceles. Many uretroceles can be causes of VUR. So they again can be detected. Basically, what we are doing an ultrasound for is to identify other co-associated congenital abnormalities of the urinary tract, which often can be comorbid, co-associated with the VUR. So that's an initial investigation that you will do in all children. First, it is non-invasive. Second, it is very safe in children. So you always go in for this as the first investigation, followed by the more problematic investigations like MCU, because problematic because it requires catheterization. And then the other investigation, which is DMSA. DMSA is not problematic, but then it is required to see for any renal scarring in children. So I hope you're all understanding whatever I'm trying to tell you, right? I'm just taking just a minute to make you understand. I hope you are all understanding whatever I'm trying to tell you. So these questions are the questions which have been asked in INICET. So the pattern of questions now you will be able to understand what type of questions. And as you can see, most of these questions are not very difficult questions. They are questions which we have discussed in our classes. We only are aiming to discuss these questions for you to understand the pattern of questions on these exams. And in case these questions are repeated, you should be able to answer those questions confidently if they are repeated in the next exams. So I hope you're all able to understand the things that I'm trying to explain through these questions. Then there is another question which was asked in INICET 2022 November. Which cyanotic congenital heart disease will increase the pulmonary blood flow? Which cyanotic heart disease will increase the pulmonary blood flow? So cyanotic heart diseases, cyanotic congenital heart diseases can reduce the pulmonary blood flow, and there can be some cyanotic congenital heart diseases which increase the pulmonary blood flow. So there are some cyanotic congenital heart diseases which reduce the pulmonary blood flow, and some cyanotic congenital heart diseases which increase the pulmonary blood flow. So cyanotic heart diseases which reduce the pulmonary blood flow will be, one is TOF and one is tricuspid atresia. But cyanotic heart diseases which will increase the pulmonary blood flow with the transposition of great arteries, total anomalous pulmonary venous return or total anomalous pulmonary venous connection, then truncus arteriosus, and then hypoplastic left heart syndrome. Hypoplastic left heart syndrome. So this I tell in my classes also. So now you can very easily answer. Tetralogy of Fallot will decrease the pulmonary blood flow. It will not increase the pulmonary blood flow. Ebstein's anomaly is an abnormality of the tricuspid valve. So naturally, when there is an abnormality of the tricuspid valve, there will be difficulty of blood flow to enter from the right atria into the right ventricle. So how will blood then go into the lungs? So Ebstein's anomaly again will lead to decrease in the pulmonary blood flow. So increase in the pulmonary blood flow will be seen in TGA and total anomalous pulmonary venous return or total anomalous pulmonary venous connection. So therefore A will be the correct answer. And I think most of you have answered A. There is one student who has answered B. 3 will not be increase in the pulmonary blood flow. Tetralogy of Fallot is decrease in the pulmonary blood flow. Remember, one component of tetralogy of Fallot is pulmonary stenosis. So when pulmonary stenosis is there, pulmonary stenosis cannot lead to increase in the pulmonary blood flow. He's asking increase in the pulmonary blood flow. So how can tetralogy of Fallot lead to increase in the pulmonary blood flow? Remember the 4 components of TOF. One is pulmonary stenosis, right ventricle hypertrophy, VSD, aorta overriding the VSD. So when there will be pulmonary stenosis, how can the pulmonary blood flow increase? The pulmonary blood flow will actually reduce. So therefore, those students who are answering B as the correct answer, B cannot be the correct answer because B is saying 1, 2 and 3. The only correct answer is 1 and 2, which means A. So I hope those who have answered B have understood why B is not the correct answer. So with this, we finish up November 2022 questions. Let us quickly now come to the INI CET May 2022 questions. The first INI CET May 2022 question is, which of the following is the best way to assess, the adequate response to ventilation during neonatal resuscitation? So in neonatal resuscitation, I have told you in my classes, I have told the techniques where we go in for the initial resuscitation, in which we go in for positive pressure ventilation, then we go in for chest compression, then we go in for epinephrine. The point is, how do we decide that we have to move from one step to the next step? It's always usually based upon heart rate evaluation. And yes, most of you have given the correct answer. Answer is heart rate evaluation. Improvement in heart rate is always the best criteria that the child is responding to that step of resuscitation. So for example, positive pressure ventilation, heart rate less than 100 or apnea is the indication. But for chest compression, heart rate less than 60 per minute is the indication. So if the heart rate is falling, it's never a very good indication. It indicates that the child is not responding to the steps of resuscitation. Heart rate increasing, improving will be the best steps, which indicates that the child is responding to resuscitation. So which of the following is the best way to assess adequate response to ventilation? It is improvement in the heart rate, and most of you have given the correct statement. Coming to question number 2. Question number 2 says, for a low birth weight neonate, what is best suited in the absence of the mother's breast milk? So when the mother is giving breast milk to the child, that's the best form of any feeding to a child. So there is no parallel to breastfeeding to the child. No parallel. In case the mother is not able to give breastfeeding to the child, the next type of feeding that we do recommend is express breast milk, because ultimately the milk that we are giving to the child is the breast milk only. It's only that we are expressing the breast milk and then we are giving it to the child. So you can take the expressed breast milk and keep it at room temperature, and you can keep the milk at room temperature for up to 6 hours, and you can keep the milk in the refrigerator for up to 24 hours. So keep the milk in the room temperature for up to 6 hours, and you can keep the milk in the refrigerator for up to 24 hours. So expressed breast milk is the next best milk that can be given to a baby. In case expressed breast milk is not available, then the third type of milk which we still can prefer is the donor breast milk formula. Now, donor banking, especially milk banking, has now started becoming very common. It's basically a form of milk that is donated by mothers who probably have excess amount of milk. So that actually is otherwise a breast milk only, not the mother of the baby, but there is another mother of another baby who has donated the milk from the milk bank that has been made available for the baby. So why is it preferred? Because ultimately this milk is the breast milk only. It's not the milk of the mother, but the milk of another mother. So ultimately all the qualities and the properties of breast milk will be present in this milk also. There are very clear recommendations that all low birth weight neonates, that means neonates who are less than 2.5 kgs in weight at birth, all low birth weight neonates should be given, if they cannot get breast milk, they should be given donor breast milk to prevent the risk of necrotizing enterocolitis. So we have to understand that any type of breast milk, it might be the direct breast milk of the mother, it can be express breast milk, or a milk from the breast of another mother. Any type of breast milk will be always better suited in comparison to that synthetic or the formula milk. This is actually the last type of milk that you will ever recommend for a baby. Formula milk is the last type of milk which you will ever recommend for the baby. So because here we have options of donor breast milk available, so our correct answer will be donor breast milk. Best form of milk will always be the mother's direct breastfeeding of the baby. If that is not possible, then express breast milk. After storing at room temperature for 6 hours, storing in a refrigerator for 24 hours. If that is also not possible, then the donor's milk can be given. And if that is also not possible, then obviously the formula milk needs to be given. And please remember, there are recommendations, very strong recommendations, that in low birth weight babies who cannot be given breast milk, a donor breast milk should be given to reduce the risk of necrotizing enterocolitis in these babies. So therefore, question number 2, the best answer should be C. And I think, yes, most of you have given C as the correct answer. Coming to question number 3. Question number 3, May 2022. Which amino acid does not need to be restricted in the diet of children who have maple syrup urine disease? So maple syrup urine disease, I'm sure you all are aware of this. This is a metabolic disorder. It's a metabolic disorder in children which is associated with deficiency of branch chain keto acid dehydrogenase. Branch chain keto acid dehydrogenase. So it's basically deficiency of branch chain keto acid dehydrogenase. So as a result, the branch chain amino acids are primarily affected. They cannot get metabolized. So which are the branch chain amino acids? BCAA is branch chain amino acids. So leucine, isoleucine and valine, these are the branch chain amino acids. Methionine is not a branch chain amino acid. So because he's saying which need not be restricted, so methionine will not be restricted because methionine is not a branch chain amino acid. The branch chain amino acids are leucine, isoleucine and valine primarily, and it is the metabolism of these branch chain amino acids that is affected in maple syrup urine disease. So these branch chain amino acids start accumulating in the blood. Their keto acids start accumulating in the urine. And many of these branch chain amino acids, particularly leucine, is very, very neurotoxic. So it can lead to persistent vomiting starting from the neonatal period. It can lead to delay in the milestones. It can also lead to seizures in these newborns. Any child who has seizures, delay in milestones, persistent vomiting, failure to thrive, and these babies are the babies who do not gain weight properly from the very early part of their childhood period. So always these babies, if there is no underlying cause which can be explained for these symptoms, then metabolic disorders such as maple syrup urine disease should be suspected, especially if there is a maple syrup odor in the cerumen and the maple syrup odor in the urine. That is why the name maple syrup urine disease. So there is maple syrup odor of urine and maple syrup odor in the cerumen. So what is the correct answer? The correct answer, yes, branch chain keto acid dehydrogenase. So methionine is not to be restricted because it is not a branch chain amino acid. Coming to question number 4. Question number 4 says, which of the following is the recommended dose for human papilloma virus vaccination in girls aged 9 to 14 years according to the WHO SAGE protocol? So recently the WHO SAGE protocol has been updated for human papilloma virus vaccine. So recently the WHO SAGE, I think SAGE is the academic partner for WHO, and this combined WHO SAGE protocol has been revised for human papilloma virus vaccine. So what does the current protocol says? The current protocol says that for all children between 9 to 14 years, either 1 or 2 doses are recommended HPV vaccine. In children between 15 to 20 years, again 1 or 2 doses are recommended. But in children who are 21 years or more than 21 years, 2 doses are recommended. So since they are asking about 9 to 14 years age group according to the WHO protocol, so what should be the correct answer? Yes, the correct answer is 1 or 2 doses. So those who are answering B, this is not correct. This is only correct for children who are 21 years, not children, adults who are 21 years or more. Their 2 doses are mandatory. But for 9 to 14 years and 15 to 20 years, the WHO SAGE protocol says that either single dose or 2 doses of human papilloma virus vaccines are recommended. How many types of human papilloma virus vaccines are there? Let me see if you can answer. How many types of human papilloma virus vaccines are currently available? Are there 1 type? Are there 2 type? Or are there 3 types of human papilloma virus vaccines? Let me see if you can answer. How many types of human papilloma virus vaccines are? How many types of human papilloma virus vaccines are currently there? Let me see if you can answer. How many types of human papilloma virus vaccines currently we have? So yes, many students are answering 3. Exactly, we have 3 types of human papilloma virus vaccines. So we have the bivalent vaccines. Yes, very good. We have the bivalent vaccines. We have the quadrivalent vaccine. And then we have the nonavalent vaccines. So we have the bivalent vaccine, especially which is effective against human papilloma virus 16 and 18. Then we have the quadrivalent vaccine, which is effective against human papilloma virus 6, 11, 16 and 18. And then we have nonavalent vaccine, which provides protection against additional strains of human papilloma virus vaccine. So there, yes, there are 3 types of human papilloma virus vaccines available: the bivalent vaccine, the quadrivalent vaccine, and the nonavalent vaccines. The bivalent vaccines are the ones which provide protection against cervical cancers. So these are the ones which provide protection against the cervical cancers. In India, they say almost around 80% of cervical cancers can be prevented by starting these vaccines very early. Especially 9 to 14 years is the target group, pre-sexual activities. So before the sexual activity starts, pre-sexual period, 9 to 14 years, that's the primary target group for giving these vaccines. You do not want to give these vaccines, or you want to avoid giving these vaccines after the virus has already entered. It will have then less protection. It is going to have more protection against cervical cancers before the human papilloma virus enters. And one of the primary routes of the entrance of this virus, as you know, is the sexual transmission. So that is why all girls 9 to 14 years, they are the primary group to which human papilloma virus vaccine should be given. The quadrivalent vaccine, in addition, will provide protection against anogenital warts also. So they do provide protection against cervical cancers, and they do provide protection against anogenital warts as well. because of that additional protection against type 6 and type 11. And the nonavalent vaccine, obviously, because it is providing an extra coverage against the other strains of human papilloma virus. So it provides about 15% additional protection. The bivalent vaccine is already providing around 75 to 80% protection against cervical cancers. Another 15% protection can be provided by the nonavalent vaccine, because obviously it provides protection against additional strains of human papilloma virus vaccine. So these are the vaccines which are very, very important vaccines, and these vaccines are recommended in all age groups. Normally we recommend, see, the question is maximum age limit to which it can be given. See, the recommendations usually are that in all children who are between 9 to 14 years of age, we give 2 doses of human papilloma virus vaccine in India 6 months apart. And in children who are 15 years plus, now that 15 years plus, till what age? Usually that maximum age limit is not defined, but we normally take it as age limit from where somewhere between 26 to 40 years. Please try to understand that more you go away from the adolescent age group and more number of sexual transmissions have occurred or more number of sexual activities have occurred, the chances of human papilloma virus entering into the body is higher. So if you give a human papilloma virus vaccine at a later age, the chances of protection will become very, very minimum. So even a nonavalent vaccine is recommended between 19 to 26 years. So they recommend till 26 years of age, not beyond 26 years. So the recommendation is, there is no defined recommendation till what age you should give. But we usually recommend that till 26 years of age, it is likely to provide protection. Above that, it's likely to provide minimum protection. There is no point of giving this vaccine in a 40 or 45-year-old women, because obviously the risk of cervical cancers by sexual transmission would be high. And this vaccine will be able to provide least protection in such an old woman. But it is likely to provide protection, much greater protection, especially when it is given to adolescent girls before their sexual activity starts. That is why I'm again and again repeating, 9 to 14 years is the target age group before the sexual activity starts. That's the primary age group when this vaccine can be given. So if you ask me what is the maximum age group when benefits can occur, I would say 26 years. Even the nonavalent vaccine, which is the vaccine which is likely to provide maximum protection, 9 to 26 years is the recommendation. 0, 1, 6 months, 9, I think 0 to 6 months, 3 doses. That's the schedule for nonavalent vaccine. Beyond that, the protection would be very minimum. Then ACTH. The next question is, ACTH is used in the treatment of which of the following? So ACTH, obviously this is a very, very simple question. ACTH is used in the treatment of West syndrome, infantile spasms. ACTH is used in the treatment of infantile spasms. Yes, C is the best answer. Infantile spasms are seizure activities or epileptic spasms which occur in infants. They are associated with epileptic spasms, developmental regression, and hypsarrhythmia. So there are combinations of epileptic spasms. There are combination of epileptic spasms, combinations with the developmental regression, plus hypsarrhythmia, which is a atypical type of or a chaotic type of an EEG activity. Basically, hypsarrhythmia are high amplitude slow wave spikes with a completely disorganized background rhythm. So this is an EEG which shows high amplitude slow wave spikes with a completely disorganized background rhythm. So Dr. West was the person who first detected these seizures, and that is why this infantile spasms are known as the West syndrome. The drug of choice for infantile spasms are ACTH injections. Usually 2 weeks we give full doses, followed by another 2 weeks of tapering dose of ACTH. They are able to control these seizures very well, especially the high dose ACTH. They have a very good effect on controlling these seizures. In case infantile spasms occur in children with tuberous sclerosis, then drugs like vigabatrin is given. But otherwise, what is the drug of choice for infantile spasms? Is ACTH. Yes. So if it is associated with the tuberous sclerosis, then the drug of choice will be vigabatrin. The third alternative is prednisolone, but prednisolone, as you know, is corticosteroids, so obviously not a very preferred choice in young children. So therefore, ACTH and vigabatrin should be taken as the first and the second choice anti-epileptic drug for treatment of infantile spasms in the order in which I've told you. First ACTH, then vigabatrin. Then coming to question number 6. Now, question number 6 says, which of the following is associated with congenital absence of the vas deferens and the seminal vesicles? Well, about congenital absence of the seminal vesicles, we still are not very sure. But bilateral congenital absence of the vas deferens, can be seen definitely in children. Let me see what your answer is. Congenital absence of the vas deferens can be definitely seen in children with cystic fibrosis. It definitely is seen in children with cystic fibrosis. See, let us see other choices. Tuberous sclerosis is a neurocutaneous disorder. So it has nothing to do with vas deferens absence. This definitely cannot be the answer. Kalman syndrome is basically a disorder which is associated with delayed puberties and lack of smell, anosmia. And there is nothing mentioned about anosmia here, lack of smell here. There's nothing mentioned here about anosmia. So naturally this rules out Kalman syndrome also. And testicular feminizing syndrome is an androgen insensitivity syndrome. It's an androgen insensitivity syndrome. In which karyotypically the child is a male, XY, but phenotypically the child is a female. So again, it is not likely to be associated with absence of the vas deferens. The only reason why I am saying that cystic fibrosis would be the correct answer is because, as I just told you, cystic fibrosis is associated with dryness of the secretions or the mucus inside the hollow structures of the body. And as you know very well, the vas deferens is a hollow tube. It's a hollow tube connecting the urethra to the testicles. So testis and the urethra connected by this vas deferens. So it is believed that during the time of development, this abnormally thick mucus can block the vas deferens, which leads ultimately to atrophy and therefore a bilateral absence of the vas deferens. So that is the probably postulated mechanism why vas deferens can be absent in some males with cystic fibrosis. So they say, as I just told you a few questions back, that cystic fibrosis is associated with dryness of the secretions inside the hollow tubes. So that dry secretions, especially mucus secretions of these seminal vesicles or mucus secretions of the vas deferens, can lead to blockage of the vas deferens by the dry mucus, which ultimately can result in atrophy of the vas deferens. Therefore, bilateral congenital absence of the vas deferens can be one of the presentation. In fact, it can be a monosymptomatic presentation of children with cystic fibrosis. Not children, I would say, but an adult with cystic fibrosis, males. So therefore, definitely the best answer to this question, congenital absence of vas deferens, will be seen in the best answer out of all the choices. I think you can come to this answer by ruling out the other choices also. So cystic fibrosis is the best answer. Coming to question number 7. Now question number 7 is a pretty simple question. They say a 4-year-old male child with a body weight of 15 kgs and a height of 100 centimeter is admitted with renal failure. So there is a child who has a body weight of 15 kgs and has a height of 100 centimeters, and the child is admitted with renal failure. The blood urea of the child given is 100 milligram per deciliter and the serum creatinine given is 1 milligram per deciliter. They are asking what is the closest calculated estimated glomerular filtration rate of this child, EGFR. What is the closest EGFR? So this is very, very simple. If I have a child whose height is given and I have a child in whom serum creatinine is also given, although there are many ways of estimating a GFR, the best bedside method for evaluating the GFR is the Schwartz formula, the modified Schwartz formula. And what is that formula? That formula says height in centimeters upon the serum creatinine multiplied by a constant K, and that constant K is 0.413. So this will give you the eGFR of the child. Yes, the Schwartz formula. So this will give you the eGFR of the child. This is the best, I think the simplest of the questions. We have all known this formula from a very long time. I think from physiology onwards, we have known this formula. You just need the height of the child in centimeters, which is given. And you also need the serum creatinine. Rest all is just to confuse you. So the height of the child given is 100 centimeters, serum creatinine is given is 1 multiplied by 0.413. So the answer comes out to be approximately 41. And which is the closest to 41? 40 should be the correct answer. So this is a pretty simple question in which I don't need to tell you anything. I'm sure you all are very familiar with this modified Schwartz formula, which is height in centimeter upon serum creatinine in milligrams per deciliter multiplied by a constant K, which is 0.413. So because the eGFR comes out to be 41, the closest answer will be 40. And I think most of you have given 40. In fact, all have given 40 as the correct answer. Okay. Then coming to the INI CET November 2021 questions. And the first question is, baby is able to roll on opposite sides at what age? So when is the baby able to roll on opposite side? So that means rolling over starts in a child at what age? Please remember, a child sits with support at 5 months. He sits without support. He sits without support at 8 months. He rolls over between 5 to 7 months. So he starts rolling over from 5 to 7 months. Then he starts to stand with support at the age of 9 months. So when is rolling over known to start? Rolling over is known to start from the age of 5 to 7. Prone to supine, then supine to prone. So first prone to supine, which is then leading to the next type of rolling, which is supine to prone. So 5 to 7 months is the time when the child starts to roll over, which is the correct form. So when does the child starts to roll over? The child starts to roll over usually from the age of about 5 months to 7 months. Yes, so it is basically related to, very good. So it is something related to the disappearance of the asymmetric tonic neck reflex. Basically, the asymmetric tonic neck reflex means that when the child's or newborns or an infant's head is turned to one side, the arm on that side extends. So that basically is a way of interfering in rolling over. So till the asymmetric tonic neck reflex is present, the child will not be able to roll over. ATNRs are primitive neonatal reflexes. Asymmetric tonic neck reflex are primitive neonatal reflexes. They appear at about 35 weeks of intrauterine life and they disappear at approximately 6 months of age. That is why in majority of children, rolling over is known to start at around 6 months of age, which is 5 to 7 months the range. So only when the asymmetric tonic neck reflex disappears. See, what is asymmetric tonic neck reflex? If you turn the head on the child to one side, arm of that side will extend. So it naturally will interfere in rolling over. The child will not be able to roll over till this reflex is present. So this reflex has to disappear for rolling over to appear. So because this reflex disappears at about 6 months after birth, that is why rolling over is known to start at about 6 months after birth. So what is the time when the child is able to roll over? The child is able to roll over at the age of 6 months. So thank you very much. It was a very apt way of defining. I normally tell in my classes this, and probably whatever you are saying is absolutely correct. So this is one of the best ways of remembering what is the time of rolling over in a child. Disappearance of the ATNRs will correlate with rolling over of the child. The next question will be question number 2. At which age a child's height is half of his expected adult height? So at what age the height of the child will be half of the adult's expected height? So suppose I take an adult expected height to be somewhere around 170 centimeters approximately. Some are shorter, some are taller. So let us say an approximate adult height will be about 170 centimeters. So now the question is, when does a child's height reaches 170 centimeters? So as I told you, the length of a newborn at birth is 50 centimeters. So the length of a newborn at birth is 50 centimeters. Then at the age of 1 year, it becomes 75 centimeters. And at the age of 2 years, it becomes approximately 85 to 90 centimeters. So now 2 years is the time when the height of the child becomes approximately 85 to 90 centimeters. And this is, as you can see, exactly half of the adult height. So if someone asks you what is the time when the child's height will become approximately half of the adult height, so considering that the adult height is about 170 centimeters, the best time when the child's height will become equal to the half of the adult height will be about 2 years. So some students are giving the answer as C. C cannot be the correct answer. At 12 months, as you can see, the height is 75 centimeters. The adult height is not 150 centimeters. If you take the approximate adult height, the approximate adult height will be around 170 centimeters. Some are taller than this, some are shorter than this. So I would say it is approximately at 18 to 24 months, roughly about 2 years of age. When the child's height reaches about 85 centimeters, it is roughly by 2 years of age when the child's height will be approximately half of the adult height. So question number 2, I think the best answer should be A. I hope you all agree with what I am saying. A should be the best answer. The reason is that at 2 years of age, the child's height is 85 centimeters, which is approximately half of the adult height. considering that the adult height will be 170 centimeters. Then coming to question number 3. Question number 3 says in a child, CSF examination is not used in the diagnosis of. Now this is pretty simple. Now ALL, AML, non-Hodgkin's, Hodgkin's, they are basically leukemias and lymphoreticular malignancies, and they are quite commonly seen in children. Out of this, the only possible explanation that I can give is, out of this, ALL, AML and non-Hodgkin's, ALL, AML and non-Hodgkin's, they often have spread through the CSF. So cerebrospinal fluid is a very, very common medium through which spread of ALL, AML and non-Hodgkin's lymphoma disease occurs to the central nervous system. It's Hodgkin's lymphoma in which the CNS spread through the CSF is very, very rare. It's very rare for a Hodgkin's lymphoma to spread to the CNS through the cerebrospinal fluid, and because of that reason, routinely you will not like to do a CSF examination in a child of Hodgkin's lymphoma, because CNS presentation of Hodgkin's lymphoma is very, very rare. It is described, but it is very, very rare. If you see the other ALL, AML, even Hodgkin's, non-Hodgkin's, the CNS leukemias are very, very rare. Sorry, very, very common. So in non-Hodgkin's lymphomas, you have primary CNS lymphomas also, and you can have lymphomas secondary to a primary non-Hodgkin's lymphoma also. Similarly, ALL and AML, they are known to commonly spread to the central nervous system, brain, through the cerebrospinal fluid. It is Hodgkin's lymphoma in which the spread through the CSF is very, very rare, and that is why routine CSF examination is not used in the diagnosis of Hodgkin's lymphoma. That's the only logical explanation that I could give to this question. Now coming to question number 4. Question number 4 says match the milestones which are mentioned in column A and their approximate age of appearance in column B. So there are some milestones which are given in column A, and there are some milestones and their ages which are given in column B. So if you are asked to compare and arrange them, what is the best way? See, social smile in a child develops at around 6 to 8 weeks. So I would say 1 to 2 months. Mature pincer grasp develops in a child at around 12 months. So 12 to 13 months can also be the answer, and 9 to 11 months can also be the answer. A child walks 1 to 2 steps, again starting from the age of 12 to 13 months also, and 9 to 11 months also. And the child transfers objects from one hand to another hand at the age of 5 to 6 months. So 1A and 4B are definitely two choices which have to be linked to each other. So now out of A, B, C, D, you see where 1A and 4D are given. Sorry, 4B, I'm sorry, 4B. 4B, 1A and 4B. The child transfers objects from one hand to another hand at the age of around 6 months, which is B option. And the child shows a social smile at about 6 to 8 weeks, which is A option. So 1A and 4B are definitely correct. So you see where 1A and 4B are given. And as you can see, it is given only in choice B. In all other choices, 1 is not linked to A, 4 is not linked to B. Therefore, the correct answer will be B. 1A, 4B, 2. Mature pincer grasp appears at 9 to 11 months, and the child walks 1 to 2 steps at the age of 12 to 13 months. So what is the best uh, way of joining them. So 1A, 2C, 3D, and 4B. I think you all have correctly answered it. Now, coming to question number 5. Which of the following does not establish a diagnosis of congenital CMV infection in a neonate? Which does not establish a diagnosis of congenital CMV infection in a neonate? See, congenital CMV infection is an infection which occurs from the mother to the child. There are two best specimens which can be used for isolation of this virus. One is the saliva and one is the urine. These are the two best specimen that can be used for isolating the virus from the child: urine and saliva. Now, how can you isolate the virus? Either you isolate the virus by culture, or you can detect the viral DNA by PCR. So you a PCR for detecting the viral DNA. The third method, which has now become very common, is a dried blood spot sample. That means blood can also be used for culture or detecting the viral DNA. So now what are the samples which can be used for isolating the virus? In the child, saliva sample can be taken, in the child urine sample can be taken, and in the child a dried blood spot sample can be taken. In these samples, either you can isolate the virus using culture techniques, or you can detect the viral DNA using the PCR technique. Cultures obviously are more cumbersome methods, time consuming methods, costly methods. PCR is a quick method which can help you in quickly telling what is the whether the specimen is positive or negative for congenital CMV. So urine culture of CMV is definitely used for isolating the virus. CMV viral DNA is used, as I told you, by PCR. We are using this technique. Now comes to choices B and choices C. See, I don't know whether this was a single answer question or it was a double answer question. In case it's a single answer question, I would still give benefit of doubt to intranuclear inclusion bodies. See, intranuclear inclusion bodies is a way for diagnosing CMV hepatitis, but it usually is not a method to diagnose congenital CMV infections. Congenital CMV infections, as I told you, the specimens have to be saliva, urine, and dried blood spot. But in case a cytomegalovirus hepatitis is there, then identification of intranuclear inclusion bodies in the hepatocytes can be the answer. Only method which definitely cannot be used is IgG, and the simple reason is IgG. IgG can be passively transferred from the mother to the child. So they definitely will never be able to tell you that this is an active infection or a virus which has passively got transferred from the mother to the child. In fact, IgM-CV antibodies in the blood can be used, IgM, but IgG-CV antibodies definitely cannot be used. So as most of you have given the answer C, C is actually a correct answer, but I would say B also is not a very correct answer. So in case there is a single answer to this question, I will still answer it as C. But B, which is intranuclear inclusion bodies, that's not used for diagnosing congenital CMV infections. For congenital CMV infections, saliva, urine, and dry blood samples, and from those samples either isolate the virus through cultures or check for the DNA using PCR. That's the only way of detecting congenital infections. But still, if I have to take out one answer from B and C, I think C definitely cannot be used for establishing a diagnosis of congenital CMV infection because of IgG. Coming to question number 6, which of these are causes of seizures in neonates? So seizures in neonates, hyponatremia, hypernatremia, hypocalcemia, hypomagnesemia. See, when it comes to seizures in neonates, there can be various causes of seizures in newborns, especially the H causes: hypoxia, hypoglycemia, hypocalcemia, hypomagnesemia, then hyponatremia, then even hypernatremia, then hemorrhage in the brain or bleeding in the brain. So they all can be, and there are many more metabolic disorders, for example. They all are important causes of seizures in the newborns. And most of these causes, as you can see, start from the alphabet H: hypoxia, hypoglycemia, hypocalcemia, hypomagnesemia, hyponatremia, hypernatremia, hemorrhage. So they all are causes of seizures in the newborns. In fact, additional causes of seizures in the newborns can also be pyridoxine, vitamin B6, pyridoxine deficiency, or pyridoxine dependence. So pyridoxine deficiency or pyridoxine dependence can also be causes of seizures in newborns. So if you now see the choices that have been given to you, definitely according to me, 1, 2, 3 and 4, they all are known to cause neonatal seizures. So hyponatremia can also be causes of neonatal seizures, hypernatremia can also be cause of neonatal seizures, hypocalcemia can also be cause of neonatal seizures, and hypomagnesemia can also be causes of neonatal seizures. Infections directly cannot cause neonatal seizures, but yes, when it leads to meningitis, then it can lead to neonatal seizures. So as I said, this is not a list which is a complete list. There is our additional list of causes, including metabolic disorders, neonatal sepsis, neonatal meningitis. The list is very exhaustive, but these are some of the important causes. And what is the drug of choice for neonatal seizures? Let me see what your answer is. What is the drug of choice for neonatal seizures? When you have childhood seizures, the drug of choice always, as I told you, is lorazepam or IV midazolam. But what is the drug of choice for neonatal seizures? What is the drug of choice for neonatal seizures? So let me see what your answer is. The drug of choice for neonatal seizures. What is the drug of choice for neonatal seizures? I told you the drug of choice for childhood seizures are IV lorazepam or IV midazolam. Yes, the drug of choice for neonatal seizures is phenobarbital. So what is the drug of choice for neonatal seizures? The drug of choice for neonatal seizures is phenobarbital. Midazolam is not the drug of choice. Midazolam is the drug of choice. IV midazolam or IV phenobarbital is the drug of choice for childhood seizures. But when it comes to neonatal seizures, the drug of choice is phenobarbital. And there is a student who's writing the depth of questions is quite high. Well, obviously you would expect the depth of questions to be high because this is INI CET. They definitely are more thought-provoking questions, more difficult questions in comparison, what I feel, in comparison to the NEET PG exams. They are more thought-provoking questions. But if you have read your notes properly, if you have read your books properly or attended your classes properly, there is no reason why you should not be successful in these exams. Let us come to question number 7. A full-term neonate was delivered. A full-term neonate was delivered via a vaginal delivery. At the 14th day, the child presents with bilateral conjunctivitis. Now, this is a very, very clear clue. The child presents to you with bilateral conjunctivitis. and the child presents to you with bilateral opacities on the lungs, which means pneumonias. So this is a child who is having pneumonia also, and this is a child who is having conjunctivitis also. And this again, I would say, is a very, very clear answer. A newborn, first thing, a newborn having pneumonia also, conjunctivitis also. Yes, it's very clear. Its answer is chlamydia. Chlamydia trachomatis is one of the best known causes of pneumonias also and conjunctivitis also in children. Chlamydia trachomatis. If you see pneumonias, if you see pneumonias in newborns, most of the pneumonias in newborns are caused either by enterobacteria such as E. coli, Klebsiella, Staphylococcus aureus, pneumococcus, and if there is conjunctivitis associated, then chlamydia trachomatis. This is a very, very important cause. This is a very, very important cause of pneumonia in a child. I am talking about a newborn, especially if there is a pneumonia associated with bilateral conjunctivitis. Please remember this clue for your exams. In case there is pneumonia in a newborn with a bilateral conjunctivitis, think of chlamydia trachomatis. Primary chlamydia trachomatis is the cause of conjunctivitis. But 20% of these children can go on to develop slowly evolving pneumonias where there will be bilateral opacities on the two sides. So because in our patient there is conjunctivitis also and bilateral opacities also, therefore the best answer should be chlamydia. Coming then to INICET July 2021 questions. The first question is intersusception is a complication associated with which vaccine? This again is a very, very simple question. I'm sure you know the vaccine which has commonly been implicated, especially the first vaccine, the first licensed vaccine of this type was associated with intersusception and had to be withdrawn from the market. So let me see what your answer is. Which is the vaccine which has been implicated in the development of intersusception? So what is your answer? Which vaccine has been implicated? Yes, it's the rotavirus vaccine. The first vaccine, which was the Rotashield vaccine in 1998, it had to be withdrawn from the market because of its association with intersusception. Intersusception is a cause of acute abdominal pain in which one part of the intestine telescopes into the other part. It's a very, very important cause of acute abdomen in young children. And one vaccine which has been associated with this as a side effect is the first rotavirus vaccine, Rotashield. The current second generation rotavirus vaccines that we have. So in India, the second generation rotavirus vaccines that we have, including Rotarix, Rotatec, Rotavac, and Rotaseal. These are the current rotavirus vaccines which we have in India. These vaccines are relatively much safer and their risk is actually very, very low. Their association with intersusception is very, very low. So even the guidelines now suggest that although there may be a very, very low risk of rotavirus vaccination and its association with interception, very low risk. But not giving a rotavirus vaccine in young children may have considerably high mortalities because of rotavirus gastroenteritis. Rotavirus gastroenteritis can be associated with very high mortality rates in young children. So not giving a rotavirus vaccine in a young child would be much more dangerous in comparison to that very small risk, I would say a negligible risk, of interception with the current second generation rotavirus vaccines, which are much safer in young children. These are oral live attenuated vaccines, much safer in comparison to that first vaccine which had to be withdrawn from the market. And that is why rotavirus vaccines are currently recommended in children. Even though there is a very small negligible risk, but their benefits in preventing mortalities from rotavirus gastroenteritis in young children far outweigh that very small risk. The next question is drug that is useful in severe COVID infection. And this again is a very simple question with a very simple answer. COVID infections in children can be mild COVID infections. They can be moderate COVID infections. And they can be severe COVID infections. Now for severe COVID infections, yes, for severe COVID infections, there is only one drug that has universally been recommended to protect these children against the consequences of severe COVID infection, and that is yes, steroids. Remdesivir, according to the government guidelines, does not need to be given in children less than 18 years of age. So remdesivir definitely is out of question. Ivermectin was used in the past, but currently there is no benefits of giving ivermectin in children with COVID infection. So the only drug that has actually been shown to be beneficial, actually steroids have been recommended in moderate COVID infections also, where there are signs of deterioration. In severe COVID infections, steroids are definitely to be given. In severe COVID infections, steroids are definitely to be given. In moderate COVID infections also, according to the guidelines, steroids should be used where there are signs of deterioration towards a severe disease. So steroids have a role in moderate COVID infections also, where there is possibility of deterioration towards a severe disease, and they have a role in a severe COVID infection also. The two steroids that are used are methylprednisolone and dexamethasone. So you can choose from among them. But they are the only drugs that are recommended universally in all guidelines for reducing down the severity in severe COVID infection. Therefore, question number 2, the answer should be steroids. Which of the following is the correct components for kangaroo mother care? Now this again is a question which is very simple question. So we have discussed this plenty of times in my classes also. Kangaroo mother care is the standard of care. It's the standard of care for low birth weight babies. It's the standard of care for low birth weight babies, especially those low birth weight babies who are hemodynamically stable and more than 1.8 kg. So those low birth weight babies who are hemodynamically stable and more than 1.8 kgs. So what are the three components of the kangaroo mother care? Three components of kangaroo mother care are prolonged form of skin to skin contact, early initiation of exclusive breastfeeding, early discharge of the child from the hospital, and continuing breastfeeding at home. So this is very simple. B is the correct answer. Early prolonged form of skin to skin contact, early initiation of exclusive breastfeeding, and early discharge from the hospital and continuing breastfeeding at home. So these are the components of the kangaroo mother care, one of the best ways to keep low birth weight babies warm. So most of you have correctly answered. Kangaroo mother care is one of the best ways to keep low birth weight babies warm, and B are the three components of kangaroo mother care. This is again a very simple question. Pentavalent vaccine. So pentavalent vaccine is a vaccine of the national immunization schedule, in which we have DPT, we have hepatitis B, and we have Haemophilus influenza B. So basically this is one of the best vaccines by which you can increase the compliance. So rather than giving multiple doses, you can give this as one common doses for 5 antigenic components or 3 infections: DPT, Hib, and hepatitis B. So it protects against diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenza B. So what is the correct answer? The correct answer is D. Pentavalent vaccine according to the national immunization schedule. So it is given at 6, 10, and 14 weeks. When is it given? It is given at 6, 10, and 14 weeks. It is given by the intramuscular route and is recommended in children till 1 year of age. It is recommended in children till 1 year of age. So it is intramuscular vaccine given in the national immunization schedule at 6, 10, and 14 weeks, and is recommended till 1 year of age. It's a combination of DPT, hepatitis B, and Hib, pentavalent vaccine. No typhoid here. So there is no typhoid in the pentavalent vaccine. The next question is question number 5. Which of the following is a true statement about congenital CMV infection? So there is another question now on congenital CMV infection. Now I again did discuss in detail about this in my classes. Congenital CMV infection, I often discuss this in detail in my classes. Congenital CMV infection is actually the most common. It's the most common congenital infection that we see in children. It's the most common congenital infection that we see in children. 90% of children with CMV are actually asymptomatic. Only 10% children with CMV, congenital CMV, are actually known to have symptoms. 90% of congenital CMV is asymptomatic. Only 10% are known to have symptoms. So A automatically is a wrong option. When symptoms are present, children usually present to us with microcephaly. They may have periventricular calcifications. They may have chorioretinitis. That's when symptoms are present. But choice B says triad of sensorineural hearing loss. Now sensorineural hearing loss is definitely very, very common in these cases. In fact, congenital CMV is considered to be the most common non-syndromic cause of hearing loss in young children. It's a most common cause of non-syndromic hearing loss in young children. So these children often have microcephalies, periventricular calcifications, chorioretinitis. But if you see the choice B, it is saying enamel hypoplasia. Enamel hypoplasia is not seen in these children. So B option is also wrong. Then C option, most children asymptomatic at birth can develop sensorineural hearing loss. This is wrong. We agree that sensorineural hearing loss risk is very high in children with CMV, but the risk is higher in symptomatic children compared to asymptomatic children. So the risk of developing hearing loss is much higher in children who are symptomatic compared to children who are asymptomatic. So C is definitely a wrong statement where we say most children who are asymptomatic will develop. No, this is wrong. Asymptomatic children can develop sensorineural hearing loss, but it's wrong to say that most children with sensorineural with the asymptomatic CMV infection will develop sensorineural hearing loss. So A, B, C automatically are wrong statements. So which is the only correct statement according to me? It is D. So some of you have answered C. C is a wrong statement. I'm not saying that sensorineural hearing loss cannot develop in asymptomatic CMV infections, but to say that most children who are asymptomatic will develop sensorineural hearing, this is a wrong statement. The risk is higher in symptomatic compared to asymptomatic. Now the question comes, why is D the correct statement? If the mother, see, CMV is very common in India, and most mothers who have infections actually have previous exposures, and the common type of infections are reactivations after a previous infection. So in India, the mothers are often infected with cytomegalovirus. Now, if there is a previous infection, say for example before pregnancy, a previous infection with CMV, IgG antibodies will be present against CMV. This will prevent the child from getting infected when the mother gets pregnant. So this is a correct statement to say that if the mother has previously been infected and has IgG antibodies against CMV, then the child is unlikely or has minimal risk for developing the infections. The risk is much higher in children born to those mothers who have previously not been infected. So therefore, according to me, the only correct statement in question number 5 is D. A is definitely wrong, B is definitely wrong, C is definitely wrong. D is the only correct statement related to congenital cytomegalovirus infection. Now, question number 6 says most common cause of death in children between 1 to 4 years. So, just remember this mnemonic. Please avoid deaths. In children and infants. Just remember this mnemonic. Please avoid deaths in children and infants. This actually gives you the rates of under 5 mortality in children, especially in developing countries like India. So prematurity happens to be the most common cause of mortality, accounting for almost 24% of under 5 deaths. A stands for asphyxias. Okay, then another P stands for pneumonias. Pneumonias also are important causes of under 5 deaths, accounting for 13% of the under 5 mortalities. A stands for asphyxias, and asphyxias account for about 12% of total mortalities, 11% to 12%. D stands for diarrheas. So diarrhea stands for about 10% of all mortalities. C stands for congenital malformations, and congenital malformations account for 3 to 4% of all mortalities. I stands for injuries, which again account for approximately 3% of all mortalities. And then infections like malaria account for about 1% of all mortalities under 5 years. Just remember the mnemonic. Please avoid deaths in children and infants. So P stands for prematurity, accounting for 24% deaths. P stands for pneumonias, accounting for 13% deaths. A stands for asphyxias, accounting for 12% of under 5 deaths. Then D stands for diarrheas, accounting for 10% of under 5 deaths. C stands for congenital malformations, accounting for around 4% of under 5 deaths. Then I stands for injuries, accounting for 3% of under 5 deaths. And then infections like malaria, accounting for about 1% of under 5 deaths. So now if you see how to arrange them, so A, pneumonia most common, followed by diarrhea, followed by injuries, followed by malaria. So therefore B should be the correct answer. So A is not the correct answer, B should be the correct answer. Pneumonias, as you see, is 13%. Diarrheas, as you can see, is 10%. Then injuries, as you can see, is about 3%. And malaria, as I told you, is about 1%. So the correct sequence should be A, B, C and D. Then a child presented with fever and vesicular lesions on the upper and the lower limb and neck stiffness. Similar lesions are present on the palms, soles and the oral cavity. CSF analysis revealed normal glucose and elevated lymphocytes and proteins. So if the glucose is normal and the proteins are increased, particularly the lymphocytes, this automatically will rule out a tubercular meningitis and bacterial meningitis, because this usually goes in favor of an aseptic or viral meningitis. Glucose normal and elevated proteins automatically go in favor of either a will go in favor of a viral meningitis. So either a herpes simplex or a Coxsackie meningitis. Now out of the two, if you typically see the hands, there are vesicular lesions that are seen in the hands. There are lesions that are seen around the mouth. So naturally the answer becomes hand, foot and mouth disease. So what is the answer? Hand, foot and mouth disease. So this automatically becomes hand, foot and mouth disease. Hand, foot and mouth disease. So C is the correct answer. Basically hand, foot and mouth disease is caused by Coxsackie and enterovirus, I think A71. Meningitis is not a very common presentation of hand, foot and mouth disease. In fact, hand, foot and mouth disease is a very benign illness, may be associated with painful ulcers in the mouth and in the hands, but most of these ulcers gradually heal by 7 to 10 days time. Meningitis is actually an atypical presentation in some of these children. So this may be a case of an atypical meningitis which is occurring as a result of hand, foot and mouth disease. So question number 7, C is the correct answer. Which of the following is seen in physiological jaundice? So which of the following is seen in physiological jaundice? So as you know, in physiological jaundice, in newborns, there is inability of the liver to conjugate the bilirubin. So inability of the liver to conjugate the bilirubin. So in newborns, you have a physiological jaundice and a pathological jaundice. Pathological jaundice are due to diseases, but physiological jaundice is usually because of inability of the liver to conjugate the bilirubin. So this bilirubin which is not conjugated will obviously lead to increase in the indirect bilirubin. It will lead to increase in the indirect bilirubin. When the indirect bilirubin will increase, naturally it will lead to increase in the urobilinogens. Which will be excreted in the urine, and there will be absence of bilirubin in the urine. So what is the things that is likely to happen in these cases of physiological jaundice? Indirect bilirubin will increase because obviously it is not getting converted in the liver to conjugated bilirubin. So indirect or unconjugated bilirubin will increase. Unconjugated bilirubin will get converted into urobilinogen. So urobilinogen will increase, and this will then prevent the bilirubin from passing in urine. Therefore, the correct answer will be increase in the indirect bilirubin, increase in the urobilinogen, and absence of, yes, absence of the bilirubin in the urine. So these are the three criterias for physiological jaundice in the newborns: increase in the indirect bilirubin, increase in the urobilinogen, and absence of the bilirubin in the urine. Then November 2020, 14-month-old child. So 14-month-old child has steroid dependent nephrotic syndrome. So this child is a 14-month-old child and a steroid dependent nephrotic syndrome. Which of the following is true statement? So they're asking which of the following is true statement, and multiple choices are correct. So this is a nephrotic syndrome child. Nephrotic syndrome child, as you know, often are on prolonged steroids, which makes the child immunocompromised. So whenever steroids are being given, naturally the live vaccines, can they be given? Live vaccines cannot be given. So the statement all live vaccines can be given is definitely a wrong statement. Because you are giving steroids for long periods of time, the child has immunocompromised status. So live vaccines cannot be given. Killed vaccines can be given. Killed vaccines can be given. Siblings should not be given. Now OPV is transmissible vaccines. So transmissible vaccines which can get transmitted from one child to another child, such as OPV, should also not be given to the siblings in the same family. So suppose a brother or sister in the same family is given OPV, this live vaccine can enter into the child because this is a transmittable vaccine. So not only should the child not be given live vaccine, but a sibling of the child of a nephrotic syndrome should also not be given vaccines which can easily get passed. For example, OPV vaccine which passes through the fecal-oral route. And pneumococcal vaccines and flu vaccines should be given to all children with nephrotic syndrome, because nephrotic syndrome increases the risk of infections, especially infections such as infections with streptococcus pneumonia and influenza. So children with nephrotic syndrome have increased risk of infections. So you need to vaccinate these children against pneumococcal vaccines yearly and flu vaccines. Not yearly, complete the schedule of the pneumococcal vaccine, and every year flu vaccines need to be given. So B, C, and D are the correct statements for a child of nephrotic. Only wrong statement is live vaccines can be given, which, as you all will understand, should never be given to these children. Now this is another question which says which intrauterine infection is commonly associated with hydrocephalus? Varicella zoster virus, syphilis, and toxoplasmosis. So they are saying which of these can be associated, which of these infections can be associated with hydrocephalus. Now, as you can very clearly see here, these are the infections, common infections, and their association with different types of abnormalities. And as you can see, varicella zoster, which is congenital CMV infection, congenital chickenpox infection, can be associated with hydrocephalus. Similarly, syphilis, congenital syphilis, can be associated with hydrocephalus. And similarly, toxoplasmosis can also be associated with hydrocephalus. So actually speaking, varicella zoster syphilis, toxoplasmosis, they all can be associated with hydrocephalus. So varicella zoster, syphilis, toxoplasmosis, all of them can be associated with hydrocephalus. So three only. Yes, this is the most common association. But varicella zoster and syphilis can also be associated. As I am showing you, varicella zoster, hydrocephalus is very commonly present in these cases. Similarly, congenital syphilis, it can be associated with microcephaly also, but it can be associated with hydrocephalus also. So all these three infections can be associated with hydrocephalus. You can take a table, make a table, and just write down for your exams some important congenital infections and their association with deformities, because this is congenital infections are very commonly asked in the exams. A child is diagnosed with hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Which of the following can be seen? So hypertrophic pyloric stenosis is a condition in which there is a hypertrophy of the gastric outlet, the pylorus part. So the pylorus part becomes hypertrophied. So the pylorus part becomes actually hypertrophied. So because of this, the child presents with vomiting starting immediately after birth. Now it will not start at birth. Usually it will start by about, usually the vomiting starts from about 3 weeks onwards. So there will be projectile vomitings, there will be peristaltic waves which will be passing in the abdomen. So when the gastric outlet is obstructed, the intestines will contract to overcome this obstruction, which will lead to peristaltic waves passing from left to right. So this is correct. Vomitings will be projectile, but they will be non-bilious vomitings. So this is wrong. There will not be bilious vomitings. They will be non-bilious vomitings. When the child will be vomiting again and again, hydrochloric acid will be lost, which will lead to hypochloremia. Because the gastric fluid contains a lot of potassium, and gastric fluid is being lost in the vomit, so the child will develop hypokalemia as well. And loss of fluid and loss of acid will lead to metabolic alkalosis. So only thing which is not seen in bilious vomitings, there will be non-bilious vomitings. So what is the correct answer? The correct answer will be D, 2, 3, 4 and 5. And yes, there will be paradoxical aciduria. So there will be metabolic alkalosis, but despite alkalosis, there won't be bicarbonates passing in the urine. There will be hydrogen ions, which means aciduria in the urine. So that is why we say metabolic alkalosis, but with paradoxical aciduria. So very good. So question number 3, the correct answer will be yes. So azithromycin is a cause of acquired hypertrophic pyloric stenosis. This is congenital hypertrophic pyloric stenosis. But macrolides, azithromycin carries a lesser risk. It's erythromycin which carries the highest risk. So macrolide group in young children, especially less than 2 weeks, carry a high risk of causing hypertrophic pyloric stenosis. And this question says a 7-year-old child presented with complaints of bedwetting almost twice a week. A detailed investigation was done to rule out organic cause. What should be the treatment plan? So this is a child who is 7 years of age. If bedwetting occurs after the age of 5 years, we call it as enuresis. And for enuresis, the treatment of choice For enuresis, the treatment of choice is always bell and alarm therapy. The pharmacological drug of choice is oral desmopressin. Pharmacological drug of choice is oral desmopressin. C is not the correct answer. The correct answer is bell and alarm therapy. This is a type of conditioning therapy. Basically, there are sensors which are attached to the mattress on which the child lies. So when the child passes the urine in the mattress at night, the alarm goes off. So the sound of the alarm wakes up the child. So when this happens again and again every night, the child gets conditioned to get woken up when he's about to pass urine. So it's one of the very, very effective ways of treating a child of enuresis, particularly nocturnal enuresis, without any medicines. But if medicines have to be used, then the drug of choice will be oral desmopressin. If oral desmopressin does not work, then yes, anticholinergics can be given. And as correctly pointed out, then those anticholinergics which can be given are tolterodine or oxybutynin. So tolterodine or oxybutynin can be used in case oral desmopressin does not work or is not available. But the drug of choice will be oral desmopressin. Treatment of choice will be bell and alarm therapy. So with this, I finish up the questions of this INICET. I hope this session was useful for you. You were able to understand the topics clearly and the explanations that I gave to these topics. I give you all, I give my best wishes for your INICET May exam, and I am pretty sure you would be successful in securing a good rank in these exams. So thank you very much for paying attention, sitting till late night and listening to these questions and their discussion of these questions. So thank you very much and goodbye.